Morning from Mazamani. Today's case is going to be about a complication that can occur as a result of a poorly or inadequately treated bladder infection or kidney infection. This is a case I saw a couple weeks ago in the urgent care clinic, and I'd like to bring that to you today as it's something I think you should know while you're out there in your clinical year. This case will be presented as I whisk my way east, so there'll be various locations throughout the day. Hello from Elkhart, Indiana, home of the RV Hall of Fame. Our patient is an 85-year-old white male who was initially seen by his primary care clinician in northern Wisconsin for a urinary tract infection. He was placed on a 10-day course of Bactrim DS, which he was instructed to take BID. He had completed the 10-day course, however, had called his primary care clinician on day 5 complaining of continued fever and some mild nausea. He was told at that time to just complete the antibiotics and to follow up after the next 5 days. When I saw patient, he was approximately 14 days out from his initial presentation. When I saw him, he was complaining of continued dysuria and urinary frequency. He also stated that over the past 24 hours, he had started to develop some nausea and some chills. When I seen him, he said he was not having any vomiting, back pain, fever, or mental status changes. More to come as we progress. Hello from a warm day in Youngstown, Ohio. Our case continues with our 85-year-old white male. His past medical history was significant only for BPH, and he had had a transurethral resection of his prostate approximately 10 years earlier. His vital signs, when I saw him, showed a blood pressure of 145/62. His heart rate was 100, and he had a temperature of 99.1. His respiratory rate was 20, and he had a pulse ox of 98. When I walked into the room, he was covered with blankets and appeared to be slightly chilled, but was non-toxic and was answering questions appropriately. His oral, neck, lung, and heart exams were within normal limits, although he was a bit tachycardic. His abdominal exam showed slight tenderness to palpation over the suprapubic area only, but otherwise was within normal limits. He had no costal-vertebral angle tenderness, and his genital and rectal exam were deferred. My initial working diagnosis at that time was pyelonephritis, with a differential diagnosis of UTI with dehydration versus sepsis, as his heart rate was mildly elevated. I ordered an IV to be started from nursing to include 1 liter of normal saline. I also ordered acetaminophen, 500 milligrams PO, and then the following labs were ordered: CBC, UA, BMP, and blood cultures ×2. Now we'll wait for our results. Hello from Toledo, Ohio, the home of the Toledo Mud Hens. Our labs returned for our patient, which I just wanted to show you here. The urinalysis returned showing definitely positive for some type of urinary tract infection versus kidney infection. His CBC came back showing pretty significant white blood cell count of 14,000 with a definite left shift, if you can see his neutrophils there. And his BMP came back showing not too bad. Kidney functions are okay. This is a non-fasting glucose, so I didn't consider that to be too bad. After diagnosis, after our patient's labs returned, a diagnosis of pyelonephritis versus urosepsis was made. Blood cultures and urine cultures were still pending at that time. I ordered 2 grams of Rocephin to be given IV by the nurse, and then after an hour or so, patient stated that he was feeling much better. His wife and daughter were with him. They had promised to keep a close eye on him at home, and he was not wanting to go to the hospital, had declined to go to the hospital to be admitted. I did add ciprofloxacin 500 milligrams PO BID to be given at home, which I wanted him to take while he was there in Madison. And then I also I wanted him to come back in to repeat the CBC and a urinalysis after 48 hours so we could take a look and see what those looked like. So we'll go ahead and kind of discuss everything here at our next stop. Hey there, we're back in Wisconsin. Just here to give you the results of his cultures. Urine culture showed right here, showed that there was E. coli, susceptible to everything again, which is a good thing. His blood culture also returned. Blood culture shows a positive result for E. coli and Enterobacteria. So positive blood culture, positive urine culture, diagnosis of urosepsis, complete discussion when I return home. So in conclusion, our patient was finally diagnosed with a case of urosepsis. I'm going to leave you with just a little bit of data for you. In approximately 20 to 30% of patients with sepsis, The primary cause is localized to the GU tract, with urinary obstruction being the most common cause. Remember back to our patient's case, he had a diagnosis of BPH and was status post a TURP 10 years prior. Other common causes for urosepsis include old age and immunosuppressant states. Alerting symptoms for sepsis are currently on the screen. Our patient had at least 3 of these. However, we didn't have a blood gas to go with our data today. The main bacterial causes for urosepsis are E. coli, Proteus, Enterobacter, Klebsiella, and Pseudomonas in the outpatient population. Treatment for urosepsis depends on local susceptibility patterns, but a third-generation cephalosporin in combination with a fluoroquinolone are appropriate for treatment. Patient's repeat labs were accomplished 48 hours after I saw him, and those all returned within normal limits. He was also told to follow up with his primary care clinician in 2 weeks to do a test for cure to make sure his urine has returned clean. So urosepsis is out there, and you guys need to be ready for it. Hopefully this road trip case will help you through that case.